Hello to all viewers. A warm welcome to my channel. I am Dr. Shivika Sethi, a national level faculty for microbiology in India. I'm also the author of the review book for microbiology, that is, Mastering Microbiology for All PG Entrants and Academics. Now, this session is the beginning of a series of videos in which I will be discussing multiple choice questions which are based on clinical cases. Okay, so we'll try to learn how to pick up the catch points which will help us to arrive at the answer easily, right? So let's get started. We have an 18-year-old student who comes to the physician because of a 10-day history of fever, chills, and sore throat. Okay, so I'm highlighting this. An 18-year-old student, age with sore throat and pharyngitis. Now, his sore throat has worsened to such an extent that he is unable to eat because he can hardly swallow. He says his 8-year-old sister also had similar symptoms, but she recovered within 2 to 3 days. So her illness was short lasting. His temperature is 38.2, pulse is 84, respiratory rate is 20, BP is within normal range. Physical examination shows slight peri-orbital edema, marked pharyngeal hyperemia, and enlarged red tonsils which are covered with exudate, along with bilateral tender cervical lymphadenopathy. So by now, some of you must have already guessed this diagnosis. It's a typical age, a young male, a young student who has exudative pharyngitis with tonsils enlarged with cervical lymphadenopathy. This is definitely leading to infectious mononucleosis. Supplementary to that diagnosis, they are also mentioning further ahead that he also has splenomegaly. Which of the following tests would most likely be used to screen for the probable infectious diagnosis? So here, please note the question is screening test for probable infectious diagnosis. Options: X-ray chest, ELISA, heterophile antibody test, and throat culture. Remember, whenever we think of infectious mononucleosis, we think of screening by certain serological tests, heterophile agglutination tests, and we confirm by specific serology, that is detecting antibodies specific to Epstein-Barr virus. Okay, so answer obviously is a screening test, that is heterophile antibodies which develop against sheep, horse, and ox RBCs. Okay, what are heterophile antibodies? These are formed, a patient is infected with infectious Epstein-Barr virus, but because of heterophile antigens, what are those? Shared antigens over classes and kingdoms. The patient is developing antibodies against sheep, horse, or ox RBCs. This is just a few, but actually there are many, many other antibodies also seen in the patients. Okay, so X-ray chest would have no role in diagnosis of infectious mononucleosis. ELISA would detect the specific antibodies against viral capsid antigens. Throat culture would be confirmatory test. It will not be a screening test. So our answer here is heterophile antibody tests. Okay. So infectious mononucleosis, also called as glandular fever, also called as kissing disease, caused by Epstein-Barr virus, which is human herpes virus 4. Transmission of EBV is classically via saliva or oropharyngeal secretions, and infection is ubiquitous. All of us already are infected with Epstein-Barr virus. Most likely because we are living in India, we had got infection when we were very small children. And what is the main target for the Epstein-Barr virus? It is the B cell. Very important to remember, what is the receptor for Epstein-Barr? It is CD21 or complement receptor 2. So the glycoprotein 350, which is present on the surface of the Epstein-Barr virus, that binds to the CD21 What is the co-receptor for EBV? It is the MHC class 2 antigen. So the GP, glycoprotein 42, binds to the MHC class 2, helping in the entry of the virus into the B cells. Okay, so main targets are the B cells. Now, once a B cell gets infected with Epstein-Barr, it leads to immortalization. What does this mean? That if we propagate these B cells in cell lines, they can be indefinitely propagated. So basically, they have become transformed cells capable of indefinite replication. Now, proliferation, the infected the B cells undergo activation. So there is polyclonal activation followed by proliferation of these B cells, and that is responsible for the enlargement of the lymphoid tissues, the enlarged tonsils, the lymph nodes, the spleen. And along with these enlarged, the proliferation of the B cells, there is appearance of the atypical lymphocytes in the peripheral blood. What are these? These are not the activated B cells. These are the atypical, rather the activated cytotoxic T cells. These atypical lymphocytes are also called as the Downey McKinley cells. So they are large cells with deeply basophilic cytoplasm with sometimes kidney-shaped nuclei or fenestrated nuclei are seen. Because there is lots of activation of the cytotoxic T cells, there is inversion of the CD4-CD8 ratio. Right? So important to remember immortalization of the B cells. Atypical lymphocytes are the activated cytotoxic T cells. Now, once the B cells are infected, after some time, once a primary infection occurs, the Epstein-Barr virus sometime it establishes latency in some of the B cells. So it becomes a persistent infection. And the EBV DNA, it circularizes in the nucleus and exists as an extra chromosomal DNA in the host cell nucleus. Now, once it has become latent, it can reactivate. So many herpes viruses have the ability to reactivate. These reactivations are associated with the shedding of the virus in the oropharyngeal secretions and the saliva. And generally, these reactivations are asymptomatic, but the patient is infectious to the others. These reactivations are limited, meaning they are controlled by the immune response in healthy people, but they lead to lymphoproliferative disease in immunodeficient. So uncontrolled replication of the B cells, that is what leads to lymphomas. The Burkitt's lymphoma, the Hodgkin's lymphoma. So a primary infection with Epstein-Barr in developing countries generally occurs in infancy or early childhood, and children infection is generally asymptomatic or it's a very mild febrile illness. Remember in this question that 18-year-old had a young sister who developed a very self-resolving infection. But in developed countries, the primary infection occurs generally in adolescence or early childhood. And this infection is usually symptomatic. It is usually symptomatic. And what does it manifest as? The glandular fever or infectious mononucleosis. Right. Incubation period of infectious mononucleosis is 1 to 2 months. There is a characteristic prodrome associated with malaise, fatigue, low-grade fever, and what is so characteristic, the most common presenting symptom is sore throat, and this is associated with enlargement of the tonsils, which are covered with whitish or grayish exudate, very closely resembling streptococcal pharyngitis. Along with that, there is tender lymphadenopathy. Usually we see bilateral cervical lymphadenopathy. Sometimes it can be manifested as generalized lymphadenopathies. Along with this lymphadenopathy, there is hepatomegaly as well as splenomegaly. The patient sometimes presents with a morbilliform or a papular rash. Sometimes the rash may be not the prime symptom of the disease, but may be precipitated if the patient is administered ampicillin or amoxicillin suspecting to be a streptococcal pharyngitis. So in that case, this rash may be precipitated. Okay. Now, generally, this infection is very like it's a not a very not very complicating disease. So most of the people undergo self-resolution in a few weeks' time, but rarely the patient may develop certain complications. Okay, what are these complications? One is upper airway obstruction because of the enlarged lymph nodes as well as the enlarged tonsils. Then Giannotti-Crosty syndrome, also called as the papillary acrodermatitis of the childhood. In fact, the most common cause of Giannotti-Crosty syndrome is a primary EBV infection. Then splenic rupture can occur, autoimmune hemolytic anemia, meningitis, encephalitis, cranial nerve palsies, transverse myelitis, Guillain-Barré syndrome, hepatitis, myocarditis, and interstitial nephritis. All these are complications of EBV. Moving on to the diagnosis of Epstein-Barr, rather infectious mononucleosis. So on hemogram studies, what we see is the WBC counts are raised. There is lymphocytosis, lots of atypical lymphocytes, 10 to 20% of them are the atypical lymphocytes. Liver enzymes are raised, and if we do a lymph node biopsy, we know because there is proliferation of the B cells, there is going to be follicular hyperplasia seen on histological examination. Okay. Coming to the diagnosis. Now, diagnosis is primarily done by serological tests, and first serological test is the heterophile antibodies, which appear against sheep, horse, and ox RBCs. These are seen in about 40% in the first week of illness, but in 80 to 90% by the third week of illness. The patient, when we are testing for heterophile antibodies, we want to remove the non-specific antibodies which may be the patient may be having earlier because of some other infection or because of administration of horse serum to the patient. Those antibodies are first absorbed by guinea pig kidney cells. Okay, so serum is first exposed to these guinea pig kidney cells. They will remove the non-specific heterophile antibodies, and then we're going to test it by the Paul-Bunel test or the monospot test. Okay, what is the Paul-Bunel test? It is the tube agglutination test in which we are detecting antibodies against sheep RBCs. More specific than the Paul-Bunel test is the monospot test, which is a latex agglutination test in which we are detecting antibodies against horse RBCs. Okay, and a titer of more than or equal to 40 indicates an acute EBV infection. Okay, so these are heterophile antibodies. But specific serology is done by ELISA, in which what is characteristically tested for are IgM antibodies against viral capsid antigens, IgG antibodies against viral capsid antigens, antibodies against early antigens, and antibodies against nuclear antigens. Okay, so let us study this table. If a patient has never been exposed to EBV infection, all these antibodies would be missing. In case it is acute infection, IgM anti-VCA antibodies will be present. IgG antibodies also are generally present. Antibodies against early antigens may start to appear, but nuclear antigens have not yet. Antibodies against nuclear antigens have not appeared. If the patient has had a resolution, you want to find out recent infection or not, IgM antibodies possibly may have disappeared by this time, but IgG antibodies are still persisting. Generally, these persist for lifelong. Early antigens antibodies have appeared. Also, nuclear antigens antibodies have also appeared. If the patient has had a remote infection, these antibodies, IgG, anti-VCA, and antibodies against nuclear antigens are persisting. If it's a reactivation, that will be diagnosed by the reappearance of antibodies against early antigens. Okay, so that is how generally in infectious mononucleosis we would have this finding on specific serology. Okay, now sometimes you get asked that infectious mononucleosis is diagnosed by all of the following except. So exception, culture. Culture, if you culture the oropharyngeal secretions or you culture the patient's blood, it is, first of all, it is a very tedious method and a time consuming method. And because EBV is anyway latent in the human, sometimes the patient not having infectious mononucleosis, may already have had the infection remotely, but you can still culture the virus from the peripheral blood or the oropharyngeal secretions because this virus is a persistent infection. Okay, so culture, remember, is not a common modality for diagnosis of infectious mononucleosis. Okay, so let's come back to the question. What were the important highlights? The age, the sore throat, sister having similar symptoms, but she recovered very soon. The patient has pharyngeal hyperemia with large tonsils, with cervical lymphadenopathy, with splenomegaly. This is so characteristic of infectious mononucleosis, a primary EBV infection. Now let us discuss a couple of more questions on Epstein-Barr virus infections and its related diseases. Now, this is a long history. Read it carefully. A 10-year-old male is brought to his physician with complaints of fever, sore throat, with multiple swellings in his neck for the last 24 hours. He is now feeling very ill and his symptoms are getting worse. Patient had been well preceding this acute presentation and he was not aware of any recent contact with anyone who was ill or had similar complaints. On examination, the patient is alert, cooperative, temperature is raised, blood pressure is within normal range, he has tachycardia, tachypnea, inflamed pharynx with enlarged tonsils. Okay. Cervical lymphadenopathy with mild tenderness over the liver as well as the spleen with accompanying hepatosplenomegaly. Jaundice is so marked jaundice is seen with a faint generalized maculopapular rash. Isn't this totally indicative of primary EBV infection? Right, let's move on. But here, instead of what the patient is having severe jaundice, that is what is troubling the patient. That is the reason he's very, very sick. Over the next 7 days, the patient continued to deteriorate, developing metabolic acidosis, liver failure, renal failure, and neurological complications. A liver biopsy was performed and that showed massive periportal necrosis. Okay, so this is a fulminant hepatitis in a patient who is having otherwise symptoms of infectious mononucleosis. Lab investigations revealed bilirubin raised, liver enzymes are raised. Serology was positive for EBV viral capsid antigens, EBV viral capsid antigen IgG as well as IgM. Both these antibodies are present. So most likely it is an acute EBV infection. The patient was initially treated with corticosteroids. So here the patient, what is going to now make you think of what could be the diagnosis. It's a primary EBV infection, but along with that the patient has become very, very sick. It has developed hepatitis, fulminant hepatitis, and that is leading to liver failure. Okay, then due to his continued disease progression, he was switched to HLH94 protocol of steroids given with cyclosporin. What is HLH? Hemophagocytic lymphohistiocytosis. He failed to respond to this treatment and he died. what is the likely diagnosis of the patient? One thing first that will strike your mind is infectious mononucleosis, going on to the severe complication of hepatitis leading to his death. So let us see what is mentioned in the options. Is this condition epidermodysplasia verruciformis? Is this Duncan's disease? Is this Burkitt's lymphoma or ataxia telangiectasia? Now, we are looking for EBV related diseases. Epidermodysplasia is ruled out. That is due to human papillomaviruses. Ataxia telangiectasia again has no relation with EBV. Burkitt's lymphoma would present as a tumor of the jaw. What is your answer? It is Duncan's disease. What is Duncan's disease, also called as X-linked lymphoproliferative disease? That's a disease due to a mutation on the X chromosome. Okay, so Duncan's disease or Portillo syndrome is our diagnosis in this patient, a highly fatal disease associated with fulminant hepatitis and hemophagocytic lymphohistiocytosis. Okay, so we already have registered this typical appearance indicative of a primary EBV infection leading to fulminant hepatitis and death. That's our diagnosis. All these are synonyms for this severe condition which often leads to the death of the male child. So what is this? It's a mutation. This condition is due to a mutation on the X chromosome in the gene which is encoding the SAP protein. SAP protein is controlling the SLAM protein. What is the SLAM protein? Signaling lymphocyte activation molecule. This SLAM protein normally controls the communication between the T and the B cells. That's its normal function. So this SLAM protein, there is uncontrolled activation of the SLAM protein because of this gene mutation, as a result of which there is massive proliferation of the B and the T cells whenever this patient has a primary EBV infection. It's only seen with this. So they have an increased susceptibility to, rather not increased susceptibility. When this patient has a primary infection, it leads to the uncontrolled proliferation of the B and T cells, which is associated with fulminant hepatitis and, as I mentioned earlier, hemophagocytic lymphohistiocytosis. Often fatal, the patient generally dies within the first few years whenever the patient gets exposed to EBV. But the children who survive months to years later may develop either lymphomas or they may develop A gamma globulinemia. Okay, so that's one more clinical case that we have discussed in this session about Portillo syndrome or Duncan's disease or X-linked lymphoproliferative disease. Let's take up another question. A 19-year-old male college student reports sore throat, so age 19, sore throat, fatigue following even normal non-taxing tasks like getting dressed and going down to breakfast. He tells you that he has been sick for 2 to 3 weeks, he has been feverish, and that his girlfriend now also appears to be getting the same thing. His tonsils are inflamed with a white exudate adhering, and cervical lymphadenopathy is prominent and is having splenomegaly. So again, the same thing, infectious mononucleosis. What is the most likely causal agent? We are going to look for the properties of Epstein-Barr virus, which is a herpes virus. So what is it? It is a double-stranded DNA virus, which is enveloped and has an icosahedral symmetry. Okay. Let's take up our last question. An 18-year-old woman presents to her physician with a 1-week history of fever, sore throat, fatigue, and myalgia. Physical examination revealed enlarged tonsils, exudative pharyngitis. Based on her clinical presentation, her physician diagnoses her with infectious mononucleosis. Because there are multiple causes of infectious mononucleosis like illness, which of the following diagnostic assays would rule out CMV as the causative agent of this patient's infection? Basically, remember that apart from EBV, which causes heterophile positive infectious mononucleosis, there are many other causes of infectious mononucleosis-like syndrome, which is also called as heterophile negative infectious mononucleosis, because heterophile antibodies do not form in those cases. Okay, so we'll see what are the other causes, but let's find out the answer here. Which of the following tests would rule out CMV as the cause of the infectious mononucleosis like illness? Let's see the answers. Negative gram stain of a throat swab, a lack of atypical lymphocytes in the patient's blood, a positive histological finding of cytomegaly, and a positive monospot test. First of all, this will be ruled out because viruses cannot be gram stained. It's an infectious mononucleosis-like disease. It is always associated with atypical lymphocytes in the peripheral blood. That does not rule out CMV. No hint of such a thing. A positive histology of cytomegaly would suggest it is CMV, not rule out CMV as the cause of this disease. But option D says it's a positive monospot test. That's a heterophile antibody test. And heterophile antibodies are only formed in infectious mononucleosis due to EBV, right? So this is our answer. This is ruling out CMV because CMV causes heterophile negative infectious mononucleosis. Okay, so let us in the end find out what are the differential diagnosis of infectious mononucleosis like symptoms. EBV, of course, that causes heterophile positive infectious mononucleosis. The rest of them would be heterophile negative infectious mononucleosis. CMV, that's the most common cause of heterophile negative infectious mononucleosis. Others include acute HIV infection, toxoplasmosis, lymphomas, HHV6 infection, streptococcal pharyngitis, viral hepatitis, rubella, and sometimes due to drugs like phenytoin, carbamazepine, and sulfonamides. So that's all in this clinical case MCQ discussion. See you in the next session.